We're going to unpack this dense, often misunderstood, and critically essential world of vitamins.
We are. You sent over a stack of sources covering, well, everything from the precise chemistry of these molecules all the way to global deficiency crises.
And even into the controversial landscape of modern supplement recommendations.
So our mission today is really synthesis. We're trying to take all the noise from the supplement aisle and just focus on the core facts.
Right.
And the absolute foundation here, I think, is the definition. Vitamins are non-energy yielding organic compounds.
Meaning they don't give you calories.
Exactly. No calories. They're supplied in tiny quantities, yet they are absolutely essential for human metabolism. And this is key. They must be supplied in the diet.
They're like the tiny wrenches and spark plugs for the engine, not the fuel itself.
That's the perfect analogy. They act as cofactors for specific vital enzymes.
And right away, we have to tackle this massive and frankly costly myth that vitamins are harmless. The sources are just crystal clear on this.
That perception is dangerous. It really is.
We see them overpromoted, frequently overprescribed, and there's this pervasive idea that, any physical illness must come with a vitamin deficiency.
Or that what we get in a normal diet is, quote, largely marginal.
Yeah, and our sources suggest these are prevalent, but often incorrect, ideas that just drive unnecessary consumption. Vitamins carry real, quantifiable biochemical stakes.
Especially at high doses.
Absolutely.
And what's truly fascinating here, and what really dictates those stakes, is the fundamental chemical split. We categorize them traditionally into two groups.
The fat solubles and the water solubles.
Right, the fat-soluble vitamins, that's A, D, E, and K. And then the water-soluble ones, which is the big B complex and vitamin C.
And that distinction, it's not just a chemistry classification, is it? It's more like a risk management profile for your body.
Precisely. The fat-soluble vitamins, they're stored extensively. We're talking primarily in the liver and in your fat tissue for really long periods.
So they stick around.
They do. And this ability to store them is why they are liable to cause cumulative toxicity or hypervitaminosis if you take way too much over time. They don't just wash out.
Whereas the water-soluble ones are the opposite.
Completely. They're meagerly stored. Any excess beyond what your body needs right now is simply dissolved and excreted in the urine. So acute toxicity is really rare.
Okay, so we've got our roadmap. We need to respect that storage risk. So we'll start by driving deep into the fat solubles A, D, E, and K. Focus on that dual nature.
Essential nutrients, but also potential toxins.
Exactly. Then we'll pivot to the water solubles, where we can get into those dramatic historical deficiency syndromes like beriberi and scurvy that just show how critical these cofactors are.
Sounds like a plan.
All right, let's begin with vitamin A, or retinol. As you mentioned, this is one of the most dramatically functional vitamins. I mean, the physiological impact is something you can literally see.
It really is the workhorse of site and structure. Chemically, it's an unsaturated alcohol with a nun ring. It exists in nature in a few forms like A1 and A2.
And where do we get it? When we talk about sources, what are we looking at?
The richest sources are animal-derived. So think marine fish liver oils, cod, shark, halibut, and then essential dairy products like milk, egg yolk, butter.
But the precursors, the carotenoids, that's what most people think of, right? Carrots.
Absolutely. The main precursor is beta-carotene, which you find abundantly in green plants. Carrots, of course, but also turnips and spinach.
And here's the key conversion fact for the learner. I found this fascinating. When you eat beta-carotene, it's not a one-to-one conversion, is it?
Not at all. It enters the intestinal wall, and theoretically it splits into 2 molecules of retinol. However, and this is a big however, only about half of that is actually utilized by the body.
That's a huge inefficiency.
It is, and it has to be accounted for in nutrition and dosage calculations. You can't just assume pure absorption.
Which is why the metrics are so important.
Exactly. The standards help us manage this. 1 microgram of retinol is equivalent to 3.3 international units, or IU, of vitamin A activity.
And the daily requirement for an adult male is actually pretty small. About 1,000 micrograms.
Or 5,000 IU, yes. It's not a huge amount in absolute terms.
Okay, let's unpack the visual cycle, because this is where the biochemistry becomes this stunning immediate function. It's the aha moment.
It really is. Vitamin A, specifically in its aldehyde form, retinol, is essential for regenerating rhodopsin.
Rhodopsin being the pigment in our retina, the light receptor.
Exactly. Think of it like that. When light hits it, the rhodopsin splits into its component parts, and that chemical reaction is what generates the electrical nerve impulse that travels to your brain.
So you can see, it's a chemical process firing a sensory signal.
Precisely. And when vitamin A is deficient, That regenerative mechanism just stalls. The system can't reset itself.
And the first symptom is night blindness.
The first, most dramatic symptom, poor dark adaptation or nyctalopia, because the system struggles to reset after being bleached by light. If the deficiency goes on, it causes irreversible structural changes to the retina and cornea.
But its role goes way beyond just sight, doesn't it? It's about general body integrity.
That's its second critical role, epithelial tissue maintenance. It promotes cell differentiation and maintains the structural integrity of all your epithelia.
The surfaces of your body, lungs, digestive tract.
All of them. And when that integrity is lost due to deficiency, you get impaired keratinization. The skin gets rough, mucous membranes dry out, and this just tanks your resistance to infection. It's also vital for bone growth, reproduction and spermatogenesis, fetal development, and immunity.
How does it affect immunity?
Well, a deficiency reduces your antibody response and impairs T lymphocyte and killer cell function. Your whole defense system gets weakened.
The systemic breakdown from deficiency sounds devastating. It really makes sense why this is still a major global public health concern.
It is tragically prevalent, especially among infants and children in the developing world. The key symptoms are just awful. Xerosis, which is dryness of the eye, Batat's spots.
Those are the foamy, keratinized lesions on the eye, right?
That's right. And then the dreaded keratomalacia, the softening and ulceration of the cornea, which leads to corneal opacities and ultimately blindness.
And systemically?
Systemically, you see dry, rough skin, keratinization of the bronchial epithelium leading to more respiratory infections, more GI infections. Diarrhea is a common sign, and impaired growth.
The stakes for deficiency are just catastrophic. So now we have to talk about the flip side, which brings us right back to that fat-soluble storage risk. Hypervitaminosis A.
This is the classic example of how a necessary nutrient becomes toxic when it's stored in excess. Your body has specific transport proteins for vitamin A.
And when you take too much, you overwhelm them.
You saturate them. When you chronically consume high doses, we're typically talking over 100,000 IU daily for months, you saturate those binding proteins. The free, unmetabolized vitamin A just spills into your circulation and causes systemic damage.
And what are the symptoms of this chronic toxicity? Because 100,000 IU sounds like a level someone could easily hit if they were, say, combining supplements and certain foods.
Oh, easily, especially if self-prescribing. The symptoms are alarming: severe nausea, persistent vomiting, generalized itching, dermatitis, dramatic hair loss, bone and joint pains, and extreme irritability.
It's a syndrome of systemic overload.
It is. And there's also acute poisoning, usually seen in children or when an adult takes a single massive dose, around 20,000 IU per kilogram of body weight. The symptoms there are severe headache, drowsiness, and explosive vomiting. It can often mimic a brain tumor.
It's staggering. The same substance that saves sight can cause such severe neurological and bone damage when oversupplied. The takeaway for vitamin A is really that storage capacity determines the risk.
Absolutely.
Now, let's address the biggest missing piece from the original script outline. Vitamin D. This is often called the sunshine vitamin, but its role is far more complex. It's almost like a hormone.
That's the perfect description.
Yeah.
It really is. Vitamin D is technically a group of fat-soluble corticosteroids. It's found in two main forms: D2, or ergocalciferol from plants, and D3, cholecalciferol from animals, and of course, synthesized in our skin.
From UVB radiation. But where do we primarily source it from food, besides the sun?
Natural food sources are pretty limited, which is a big reason deficiency is so common. Fatty fish, liver, and egg yolks have D3.
Which is why so many things are fortified. Milk, cereal.
Exactly. Because of this scarcity, many countries mandate fortification. But regardless of the source D2 or D3, it has to be hydroxylated twice, once in the liver and again in the kidney to become the active form, calcitriol.
And calcitriol is the true hormonal regulator.
That's right.
Okay, so let's unpack its primary role. Everyone knows it's about bone health, but how exactly does it maintain our calcium levels?
Its job is to maintain normal plasma levels of calcium and phosphate. And it does this in three main ways, acting on three major organs. First, the intestine.
Okay.
It dramatically increases the absorption of dietary calcium and phosphate. Second, the kidney, where it enhances the reabsorption of calcium.
So it pulls more in from food and it stops it from being lost in urine.
Exactly. And third, the bone. When your calcium levels are low, it works with parathyroid hormone to stimulate bone resorption, which releases calcium back into the bloodstream.
So if vitamin D is missing, those three mechanisms fail and the body just can't maintain the scaffolding of the skeleton.
Precisely. Deficiency causes those classic bone diseases. In children, the failure to mineralize growing bone leads to rickets.
The soft bowed legs and deformities.
Yes. In adults, it's osteomalacia, which is characterized by bone pain and muscle weakness. But the modern concern is that widespread, chronic low-level deficiency is linked to reduced bone mineral density, muscle weakness, and maybe even elevated risks for certain autoimmune and chronic diseases, though the evidence for that last part is still developing.
Right. Given that we can make it from sunlight, why is deficiency so prevalent even in sunny places?
There are a few critical modern factors: increased indoor living, for one, cultural clothing practices, and the widespread and very necessary use of sunscreens.
Sunscreen has a huge impact.
Massive. An SPF of just 8 can reduce vitamin D production by 90% or more. Plus, people with darker skin pigmentation, the elderly, and those at higher latitudes all have difficulty producing enough.
Let's pivot back to the fat-soluble risk profile. Since it's stored, is toxicity a serious concern?
Absolutely. Vitamin D is perhaps the most toxic of all vitamins in high excess, maybe even more so than vitamin A. Chronic excess leads to hypercalcemia.
Too much calcium in the blood.
Right. And that's dangerous because it leads to calcium deposition or calcification in soft tissues.
So calcium being deposited where it shouldn't be.
Correct. We're talking calcification in the kidneys, which can lead to renal failure, in the arteries, contributing to cardiovascular damage, and even in the lungs. The initial symptoms are vague, nausea, vomiting, frequent urination, lethargy. That storage capability means overdose is a cumulative risk.
Which reinforces the need for really controlled supplementation.
Especially with those high-dose preparations you see everywhere.
Okay, let's transition to vitamin E, or alpha-tocopherol. This one always enters the public conversation as a shield, the free radical fighter.
That's right. Vitamin E is actually a number of tocopherols, but alpha-tocopherol is the most abundant and biologically potent form.
And sources are mainly vegetable oils.
Primarily. Sunflower, corn, soy oils, also cereal grains, nuts, and green leafy vegetables like spinach. The daily requirement is around 10 milligrams for an adult male.
I found it interesting that the sources noted the requirement goes up if you have a high intake of polyunsaturated fats. What's the link there?
That's a key functional clue. The primary role of vitamin E is as a lipid-soluble antioxidant. Polyunsaturated fats, like in those vegetable oils, are highly susceptible to damage from oxidation lipid peroxidation caused by free radicals.
So vitamin E protects them?
Yes, it resides in cell membranes and acts as the body's sacrificial protector. It quenches those free radicals before they can damage the fatty acids in the cell wall. So if you increase the substrate, the polyunsaturated fats, you have to increase the protector, vitamin E.
And because of this beautifully clear mechanism, it's been aggressively promoted for preventing chronic diseases, heart disease, cancer, you name it.
Which raises a profoundly important question we need to spend some time on. Does a clear biochemical mechanism translate into an effective clinical outcome when you supplement on a mass scale?
Right. Observational studies have often been compelling, suggesting benefits like a reduced risk of heart disease.
Yes, or possibly a decreased risk of hip fracture in postmenopausal women with high intake. The suggestions are there.
But the clinical verdict, when researchers run randomized, double-blind trials, has often been, well, disappointing, hasn't it?
It has. The evidence base for large-scale prophylactic use of vitamin E is highly equivocal. It often fails to demonstrate efficacy. It's a massive disconnect.
Why do you think that is?
It could be a number of things. Bioavailability, the synthetic version in supplements might not be as active as the natural form, or maybe the free radical damage is just too advanced in a chronic disease setting. Or perhaps vitamin E needs other cofactors like vitamin C or selenium to work optimally in a living system.
Something a single-dose supplement doesn't account for.
Exactly. The fact remains, the evidence for widespread benefit for healthy people just isn't there in the clinical data.
So where does vitamin E actually shine therapeutically?
In very specific, targeted cases. Treating premature infants with retrolental fibroplasia is one example. It's also used in specific anemias, like in G6PD deficiency, which is a genetic condition where red blood cells can't protect themselves from oxidative stress.
And crucially, the toxicity profile. How does it compare to A and D?
Dramatically different. Large chronic doses of vitamin E have generally not produced significant toxicity. It's relatively safe compared to its fat-soluble cousins.
So the side effects are mild.
Very mild. Some cretinuria, maybe temporary impairment of wound healing, mild GI upset. But there is one important clinical interaction warning.
What's that?
Vitamin E can interfere with iron therapy. So you need caution when treating patients with iron deficiency anemia.
Got it. Okay, finally, we introduced the last of the fat solubles, vitamin K. This one has perhaps the most dramatic, immediate life or death function.
Blood clotting. Its name, K, actually comes from coagulation, which perfectly sums up its role.
So if vitamin D is the hormone of bone, vitamin K is the essential element of the coagulation cascade. How does it work?
It's essential for the synthesis of four crucial blood clotting factors. Factors 2, ZI, X, and X. It acts as a cofactor for an enzyme that carboxylates these proteins. Think of it like tagging them, which is necessary for them to bind calcium and become active in the clotting process.
So without vitamin K, the body makes the proteins, but they're non-functional. They're just blank forms.
It's exactly biologically inactive. If you're deficient, you can't form a clot properly. Sources are green leafy vegetables, liver, and our gut flora also contributes significantly.
And deficiency is rare in healthy adults.
It is, but it's a critical concern in two groups. The first is newborns.
Right. Hemorrhagic disease of the newborn.
Yes. Newborns have sterile guts and low vitamin K stores, making them susceptible to serious life-threatening bleeding. This is why a prophylactic dose of vitamin K is standard practice for newborns worldwide.
And the second group.
People with malabsorption syndromes, or those on broad-spectrum antibiotics that can wipe out the gut bacteria producing K2.
This raises a really important point. If vitamin K is the key to clotting, what happens when a patient is taking anticoagulants to prevent clotting?
This is where it gets truly fascinating in the world of drug interactions. The common anticoagulant drug warfarin works by being an antagonist to vitamin K.
It blocks it.
It blocks the enzyme that recycles vitamin K back into its active form. This essentially depletes the functional vitamin K, preventing the synthesis of those active clotting factors.
So warfarin therapy is basically inducing a controlled, managed, mild vitamin K deficiency.
Precisely. And this is a powerful clinical takeaway. If a patient on warfarin suddenly eats a lot more vitamin K, say, by loading up on spinach, they reduce warfarin's effectiveness, risking a clot. Conversely, if bleeding occurs, vitamin K is the literal antidote to warfarin overdose.
It's incredible. The interaction just highlights the functional power of these molecules. It's not just nutrition. It's about controlling the body's most sensitive chemical pathways.
That's right.
Okay, the fat solubles are clearly defined by their storage risk and potential for toxicity. Let's transition now to the water solubles, which offer a completely different risk profile. They don't linger, but their absence leads to rapid, severe dysfunction.
Yes, the B-complex vitamins are the coenzyme workers, the ultimate metabolic facilitators. They're incorporated into things like NAD and FAD that run the body's energy production. Since they're quickly excreted, you need a constant supply.
Or deficiency shows up fast and, well, dramatically. Starting with thiamine, vitamin B1, this one is directly linked to how we use our primary fuel source, carbohydrates.
Thiamine is concentrated in the outer layers of cereals, like rice polishing, pulses, nuts, yeast, and meat.
And its functional role is pure bioenergetics, right?
Absolutely. It acts as a coenzyme, thiamine pyrophosphate, or TPP, which is critical in carbohydrate metabolism. It helps convert pyruvate to acetyl-CoA, letting energy move into the citric acid cycle.
So without it, the body can't effectively burn glucose for fuel.
And that failure hits the tissues with the highest energy demand hardest, the nervous system and the heart. It also plays a direct role in neuromuscular transmission.
Which manifests as the historic disease Beriberi.
Yes, and the symptoms depend on where the energy failure hits. You have dry Beriberi, which is primarily neurological.
Peripheral neuropathies, muscle weakness, the characteristic foot drop.
Right, and confusion, lethargy. Then you have wet Beriberi, where the cardiovascular system fails, causing palpitations, breathlessness, and high-output cardiac failure.
That can lead to congestive heart failure and rapid death.
It can. It's staggering to see such severe failure caused by the lack of such a tiny compound.
And here's where the clinical context is so vital, the connection between thiamine deficiency and chronic alcoholism.
This is a critical link.
Sure.
Chronic alcohol abuse leads to severe nutritional deficiencies, and it really impairs thiamine absorption. The resulting lack of TPP causes the most serious neurological syndromes associated with alcoholism.
Wernicke's encephalopathy and Korsakoff's psychosis.
Exactly. Wernicke's is the acute phase severe confusion, eye movement abnormalities. And if it's not treated aggressively, it progresses to Korsakoff's psychosis.
Which is that devastating, irreversible memory disorder.
Yes, characterized by confabulation and venting memories to fill in the gaps. Because of this, treatment for alcohol intoxication requires massive, immediate intervention, typically 100 milligrams daily, often intravenously, to bypass that compromised absorption.
Okay, if B1 starts the carbohydrate engine, riboflavin B2 provides the fundamental components that keep the energy chain running.
Riboflavin is a yellow compound found widely in milk, egg, liver, and green leafy vegetables. Its role is fundamental to all cellular life. It's the precursor of FMN and FAD.
Flavine mononucleotide and flavine adenine dinucleotide. These are the essential molecular shuttle buses for energy, correct?
That's the perfect analogy. They are two absolutely essential coenzymes in oxidation reduction reactions. They're integral to the electron transport chain, the actual process of cellular respiration that generates ATP.
They carry the electrons.
They accept and donate hydrogen atoms and electrons, facilitating that orderly flow of energy.
And when this energy flow slows down, the symptoms of erypoflavinosis are often visually concentrated around the mouth and skin.
That's right. Deficiency primarily manifests as lesions in areas with rapid cell turnover. So angular stomatitis, cracking at the corners of the mouth chylosis, cracking of the lips, and glossitis, where the tongue is sore and magenta-colored.
Okay. Now, niacin, vitamin B3, is the central figure in one of the most tragic historical deficiency stories, pellagra. But let's start with its unique chemical origin.
Niacin is unique because the body can synthesize it from the essential amino acid tryptophan. The conversion factor is crucial. 1 milligram of niacin is equivalent to 60 milligrams of tryptophan.
Which means if you consume enough high-quality protein, your body can partially self-sustain its niacin levels.
Precisely. Which is why its sources are protein-rich foods, liver, fish, meat. And its coenzyme role is perhaps the most famous in biochemistry. It forms NAD and NADP.
Like FAD, these are central to virtually every oxidation reduction reaction in tissue respiration.
They are the primary electron and hydrogen acceptors in catabolism.
If these coenzymes fail, every energy pathway in the body just stalls. Let's talk about pellagra, linked historically to diets heavy in untreated corn.
Pellagra is known historically and clinically by its cardinal manifestations, often called the 4Ds. A truly devastating cascade.
First is dermatitis.
Yes, a characteristic symmetrical sunburn-like rash on exposed skin that cracks and keels. Second is diarrhea, severe GI issues, painful enteritis.
Third is dementia.
Neurological symptoms, headache, insomnia, memory loss, anxiety, eventually psychosis. And the fourth D
is death. If untreated, the condition is fatal. It's incredible to think that was once misdiagnosed as an infectious disease.
It perfectly illustrates the concept of essentiality. Replacing niacin is dramatically effective. Treatment of full-blown pellagra requires high therapeutic doses, up to 500 milligrams per day, and the results are often rapid.
Moving on to pyridoxine B6. This vitamin story is tightly woven with the central nervous system and, importantly, drug metabolism.
Pyridoxine, pyridoxal, and pyridoxamine are the three related compounds of vitamin B6. Sources are widespread. Liver, meat, eggs, soybean, whole grains.
Its function seems to be the most diverse in the B complex, especially for brain chemistry.
It acts as a coenzyme for a massive number of reactions, particularly in amino acid metabolism, and most critically, the synthesis of several essential neurotransmitters, including serotonin and GABA.
GABA being the brain's primary inhibitory neurotransmitter, the chemical brake pedal.
Exactly. It's essential for calming neural activity. When pyridoxine is deficient, the fall in brain GABA levels is immediate and dramatic, leading to severe neurological symptoms. Peripheral neuritis, confusion, and, crucially, convulsions, especially in infants.
And here's where it gets so specific and essential for the learner, the required supplementation due to drug interference. This is a mandatory metabolic antidote.
This is a textbook case. Isoniazid, a drug used to treat tuberculosis, is the primary culprit. It reacts chemically with one of the active forms of B6, forming a complex.
Which then gets excreted, so the drug effectively grabs a vitamin and throws it out of the body.
That's precisely what happens. This creates a secondary B6 deficiency, which manifests as severe peripheral neuropathy. So for any patient on isoniazid, mandatory simultaneous B6 supplementation is required.
Okay, before we move to vitamin C, let's quickly round out the B complex with pantothenic acid, B5, and biotin.
Pantothenic acid B5 is incredibly widely distributed. Its key function is serving as a foundational component of coenzyme A.
The master metabolic hub.
It is. So deficiency is extremely rare, causing vague symptoms like fatigue and cramps. And biotin acts as a coenzyme for carboxylases, crucial for fatty acid synthesis. Deficiency is also rare.
But there's that fascinating note about raw egg white.
Yes, biotin absorption is inhibited by avidin, a protein in raw egg white. So a sustained Rocky Balboa diet could actually induce a functional biotin deficiency.
Wow. Okay, so that really underscores the principle of the water solubles. Constant replenishment is mandatory.
And when the supply chain breaks, the metabolic consequences are quick and catastrophic.
Let's turn now to vitamin C, ascorbic acid. Structurally, it's a 6-carbon organic acid that looks remarkably similar to glucose.
Which is a key reason most mammals can synthesize it. But humans, primates, and guinea pigs cannot. We lost the necessary enzyme somewhere along the way.
So we are obligate consumers. Sources are well known: citrus, lemons, oranges, but also green chilies and potatoes. The daily requirement is about 60 milligrams.
It's easily absorbed and, while water-soluble, it is stored in high concentrations in certain tissues, like the adrenal cortex.
But its defining role is structural integrity. This
Yeah.
is where the historical drama of scurvy originates.
Exactly. Vitamin C is absolutely essential for the formation and stability of collagen. It acts as a reducing agent in the hydroxylation of choline and lysine. Without that step, the collagen molecules can't properly cross-link to form their stable triple helix structure.
So if you lack vitamin C, the body's fundamental support structures, connective tissue, blood vessel walls, bone matrix, they all disintegrate.
That is scurvy. Severe deficiency is rare now, but the symptoms stem directly from this defect. Capillary fragility, causing widespread bruising, bleeding gums, petechial hemorrhages. It causes edema, impaired wound healing, and anemia.
It plagued sailors and soldiers on long voyages.
It did. Its role in iron metabolism is also crucial. It significantly enhances non-heme iron absorption in the gut.
How does it do that?
By reducing ferric salts to the ferrous form, which is the form that's readily absorbed, it's frequently used to treat anemia secondary to iron deficiency because of this.
Okay, we have to address the elephant in the room. Vitamin C and megadosing. It's probably the most widely used vitamin for general health, often in gram doses.
This is the epicenter of the prophylaxis versus deficiency debate. Large doses, 2 to 6 grams daily, are advocated for everything from the common cold to adjunct cancer therapy.
What do the sources say?
They're consistently clear that no definitive large-scale clinical benefit has been proven for most of these conditions. The results remain inconsistent.
What are the risks of chronically taking those high doses, even if it is water-soluble?
Well, while it's generally well tolerated, there are 2 measurable risks. First, rebound scurvy. If you abruptly stop megadosing, your body can be metabolically adapted to low levels, causing transient deficiency symptoms.
And the second risk?
An increased risk of oxalate stone formation in the urinary tract, as ascorbic acid is metabolized into oxalate. The risk is small, but it's significant for chronic users.
This brings us to a crucial synthesis point. We've seen that the functional roles of vitamin A, vitamin E, beta-carotene, and vitamin C all converge on the same task: protecting the body against free radicals.
This is the unified theme in supplement marketing, and the mechanism is sound. Free radicals are unstable molecules that damage cell membranes and DNA. Antioxidants quench them.
So the mechanism is sound, and there's a biological basis for linking oxidative stress to chronic diseases. The critical question remains: does supplementing a healthy diet with concentrated antioxidants translate to mass disease prevention?
The current conclusion from large clinical trials suggests the evidence for overall benefit in healthy populations remains highly equivocal. Getting antioxidants through a diet rich in fruits and vegetables is clearly beneficial.
But isolating 1 or 2 and taking them in pharmacological doses doesn't seem to replicate that benefit.
It doesn't. In some studies, like high-dose beta-carotene in smokers, it actually showed negative outcomes. It seems the body's natural homeostatic balance is often superior to a high-dose, isolated intervention.
Before our final summary, let's briefly touch on the practical side, the nomenclature. It's not just one compound, is it? It's retinol versus retinol palmitate, or thiamine versus thiamine mononitrate.
This highlights the technical complexity. The various chemical forms affect critical things like stability, absorption, and shelf life. It dictates how it's manufactured and delivered.
And this brings us back to the core, undeniable purpose. The sources detail extensive use for generalized health, but the definitive proof of efficacy is always tied back to treating specific deficiency diseases.
Exactly. Niacin for pellagra, thiamine for beriberi, vitamin C for scurvy. These are clinical triumphs. These molecules are essential biochemical cogs. When a cog is missing, replacing it solves the massive metabolic failure.
But adding more cogs to a normally functioning engine doesn't automatically improve its speed or efficiency.
And often, as we saw with the fat solubles, it can simply jam the works.
This has been a necessary and, I think, deeply analytical deep dive. We've managed to extract the crucial details, moving past the aisle packaging to the molecular mechanism.
I think so too. We established that critical life-altering difference between the fat-soluble vitamins A, D, E, K, which are stored and carry a real risk of cumulative toxicity.
Right, like the severe hypervitaminosis A and D we detailed. And we contrasted those with the water-soluble B and C vitamins, which are excreted and lead quickly to deficiency if the supply is cut off.
And we saw how dramatically those deficiencies are linked to the mechanism. The breakdown of the rhodopsin cycle leads to night blindness for vitamin A.
The lack of NAD synthesis causes the cascade of pellagra for niacin. The defect in collagen results in scurvy for vitamin C.
We also highlighted that vital clinical context around antioxidants. The mechanism is sound, but the aggressive promotion for large-scale disease prevention often outpaces the clinical evidence.
Urging skepticism about those generalized claims.
And of course, that essential targeted clinical knowledge. The critical drug interactions, like the TB drug isoniazid depleting B6 stores, requiring co-supplementation.
Or warfarin being a controlled chemical antagonism of vitamin K.
This entire exploration just underscores that precise functional knowledge is essential for safe application, whether it's nutritional, preventative, or therapeutic.
So here is our final provocative thought for you to mull over as you navigate the supplement aisle. We've established that the entire physiological purpose of fat-soluble vitamins is to be stored and used slowly, and that the risk of cumulative toxicity, especially with vitamins A and D, is very real. It occurs at high chronic doses far above the nutritional requirement.
They're designed for storage.
Exactly. So if these vitamins are designed for storage, what does this deep dive imply about the safety and the true necessity of chronically taking mass-marketed, high-dose daily multivitamins for general wellness versus the precise targeted treatment of a known, confirmed, and quantifiable deficiency? Our sources clearly show that the line between nutrient and toxin is defined by storage capacity, urging critical thinking about chronic oversupply when a deficiency isn't actually confirmed.